Hey everyone, I'm John Lynn, the founder and chief editor at Healthcare IT Today, and we're excited to bring you another in our series of interviews with top leaders in health IT. And our guest today is Peter Bonis. He's chief medical officer at Wolters Kluwer Health. Welcome, Peter.
Hey, John, I'm happy to be here.
Yeah, so excited for this discussion. I've been waiting for this announcement. I literally, when it came, I said, when is UpToDate going to do this? So I'm excited to learn more about how you're executing on incorporating some generative AI into your product. But before we go there, tell us a little bit about yourself and Wolters Kluwer Health.
So starting with Wolters Kluwer, it's Wolters Kluwer, which is the parent, is a global provider of professional information and expert solutions and services, and has verticals in healthcare and tax and accounting, environmental and social governance, which is our newest vertical, finance, compliance, and legal. It's an old company, was founded in 1836. And the health division provides clinical, technical, evidence-based solutions that help clinicians and patients and researchers and students and trainees. And my entrance to Wolters Kluwer came through one of the acquisitions, UpToDate. So before UpToDate, I had done training in internal medicine, gastroenterology, and hepatology, and then another fellowship in health services research. And I was at the faculty at Yale School of Medicine when I got that call that changes your life from the founder of UpToDate, Bud Rose. And Bud was compelling. I remember I just didn't want to talk to him, but he kept me on the phone. He invited me to come to Boston and out to lunch, and he took me to one of the more unfortunate pizza places around. And then he had no money, so I bought him lunch. And but it was a great meeting. And within a month of that meeting, I actually resigned my position and went to what was a startup. And I thought that Bud's vision could potentially change the way healthcare or medicine is practiced, and hence healthcare itself. So I was caught up by the vision, and I'm incredibly thrilled that, and I'll talk more about UpToDate later, that we've achieved that vision to an extent that no one really could have imagined at the time.
Yeah, what a beautiful story. That's so fascinating. And I preface that you've incorporated some generative AI into UpToDate, but before we dive into that, give people an understanding of what UpToDate is. Ironically, I think every doctor knows what UpToDate is. Every clinician does because they use it all the time, right? It's such a dominant piece of how they look at clinical education. But for those who don't know, give them a kind of an overview of what UpToDate is.
Sure. So the problem that Bud recognized was that clinicians had a lot of questions at or near the point of care, and they couldn't answer all of those questions with the resources that are available. But if you could answer all of those questions or get close to them, that you could substantially change their decision making, and that decisions would be better and lead to better patient outcomes. So UpToDate is a knowledge resource that's now used by more than 2 million clinicians in 190 countries, and
Wow.
they use it a lot. So it's roughly 1,500 times a minute someone's looking something up in UpToDate. So it helps them answer the clinical questions around the point of care, and they trust the information, and they trust it enough that they actually can act on that information to help them deliver the best possible care. So it is not an information aggregator. All of that information UpToDate, and that's 12,000 topics, 25 medical specialties. It's all original. It's a handpicked faculty. It's more than 7,400 clinical experts. These are the kinds of people that you would like to see or have a family member see if you had a condition that they're expert at. And then we have editors and peer reviewers. We have 50 plus deputy editor physicians who work most of the time for UpToDate, and they're specialists themselves. Many of them continue to see patients. They're trained in evidence-based medicine and in writing. And then all the content is maintained by regular review of the biomedical literature, other sources of evidence, to make sure that the recommendations are current. But I want to make sure that I emphasize the rigor of this process. So we are obsessed editorially with getting it right, because we know that we're influencing real patients, and everyone feels that as they're working on creating UpToDate. And we're most proud that now UpToDate has been studied by us and by many others, external investigators. And the use has been associated with measurable improvements in decision-making and learning, and in health outcomes, including quality of care efficiency and reduction in mortality across care settings. And not only in the United States, but through our donations program, we're able to see these benefits in low and middle income countries as well.
That's awesome. It was about 15 years ago. I had a guy write on one of my blogs, and he wrote that the body of medical knowledge was so complex that the human mind couldn't comprehend everything that was happening. Now this is 15 years ago, right? Like when you said that it was so complex. And when I first saw UpToDate, I thought to myself, this is proof that he was right. Like that the amount of research, the amount of knowledge in just the medical knowledge, forget about incorporating the individual personal data, but the just the research knowledge is so complex that it's hard for a human to as great as our doctors are and as many studies as they read and as many things as they follow and consume, it's hard for them to do. Is that what you found? I mean, it feels like, as you said, when you talked about how many peer reviewers you have and how many, people you have looking at the research, is that the reality we face today when we talk about UpToDate?
Well, I mean, that has been the case for a long time with the growth of the biomedical literature, which is occurring geometrically, and nobody could really keep up with all of that, much less
Yeah.
to understand the nuances and the finer points of what's quality, and then to consider not just one study, but a body of evidence. And then to add that complexity, we have now new sources of data like real world evidence, which is emerging, things which are presented in preprint forms, things which are
Right.
presented at national meetings. So there's a lot of information to distill to separate the wheat from the chaff. And the problem has gotten much worse. So yes, I don't think anyone, even potentially if you're in a very, very, very focused specialty, you can keep up with the entirety of your literature. But for most healthcare practitioners, they need an auxiliary brain that they can actually consult and trust, and to help them to either reinforce their decisions or actually in some cases, very often change their decisions.
Yeah. Well, it's powerful. Obviously, that's why millions use it. But let's get to your announcement. You have a new announcement called AI Labs that's available in UpToDate. Talk to us about how that works.
Sure. So in a nutshell, it's an experimental instance of UpToDate at the moment. It leverages the large language models, and it allows us to collaborate with partners to further develop it, which then those partners are mainly large health systems. Sure. So to get sort of a level deeper, we're using state-of-the-art technology from our industry partners, but we've added just a substantial customization to it. So our approach now from the user's perspective takes advantage of 4 core benefits of the large language models. So the first is that it understands natural language so that users can convey their intentions, what they really want to understand or find out about, with much greater clarity. The second point is that it has search technology that allows us, and augmented by what we've done, to help concise answers to the question in context. So that saves a lot of time and browsing, and we try to save as much time as we can. The third thing we do is we maintain context, just like the experience of people who've used Bard or ChatGPT. So if you have a follow-up question, you can ask that follow-up question. We understood what domain you're talking about. So the interaction there is very much like you would have with a trusted colleague saying, but what about this? What about that? And so on. And then the last thing that we're experimenting with is creation of synthetic content that provides summaries, not from the internet or other sources, but only from UpToDate. And just a point on sort of our philosophy on this,
Yeah.
as I mentioned, we're obsessed with getting things right, and do the best that we can. So we are committed to setting a standard for safe and effective use of AI, because the domain is high stakes, it's clinical care, clinical decision making. So we have across Wolters Kluwer a lot of experience with AI in general. So more than 50% of Wolters Kluwer digital revenues come from products that already have AI within it.
Wow.
And those are a range of things like diversion of medication, detection of diversion of medications, helping nurses to stay educated with personalized learning. So AI in labs is not intended for clinical use. So we're working with those partners. We hope that it's going to enhance clinical decision making. We certainly will not release it unless it's safe. So with 2 million users, when we get over that line, I think we have a potential to really have a major impact in how information is sort of sought and retrieved, and hopefully that will make a difference.
That's interesting. I mean, I want to talk about that point about, making sure that the quality is there. Because how do you ensure that this AI labs doesn't have the hallucinations that we see and hear about in ChatGPT and other generative AI like it? What have you done to ensure there aren't these hallucinations? It's interesting you're pulling from the UpToDate, which I think may be the first step. But how do you approach that?
Yeah, so I think the entire organization and including very much me, very, very concerned about that issue. And certainly all of us have run into it. So for listeners who sort of may not fully get that, the point is not only that when you're looking at some of the commercially available large language models that the information is not correct, but it's said with such conviction, it sort of camouflages that it isn't correct. So an example, I searched an area that I happen to be clinically expert in, and it produced a reference, and it was from a prestigious journal. I knew who the authors were. It had a compelling title, but I had no idea that the study was published, which really surprised me. And it wasn't. It didn't exist. So then my next prompt was, "Did you make it up?" And sort of churlishly, it came back and said, "Yes, I did. I'm still learning." So we can't have that happen in a clinical domain for it. So the way we've approached it is we've got a human and a technological approach. So the human approach is regular peer review by trained clinicians, and then we are routinely incorporating feedback from our users and our testers, and we have an underlying machine learning model. And then we have transparency of all the sources of information so that anything that we excerpt and any synthetic content is linked very clearly back to the UpToDate section from where it came from. So they can go and see just core UpToDate that's human curated to make sure that we're on track. The technological solution is what I sort of already mentioned. So we've limited it to UpToDate's content. So we're not using an open large language model where you can take information off the internet. And so we try to maintain with sort of tweaking the core models, the integrity of the content. Still, as I mentioned, we're keeping that, at least that synthetic component, which I think is the riskiest for hallucinations, on a very short leash. And we will not release it to general availability or clinical use if we find it to be inaccurate. But so far, I'm pretty optimistic. It's really quite compelling how good it is.
Interesting. Well, and it's beautiful that you're linking back to the original UpToDate source info. That helps as well. Talk to us about where we're headed with clinical decision support and tools like UpToDate. And maybe I just haven't tracked it well enough, so this may be somewhat my ignorance, but there's probably others in our audience as well. How shouldn't this just be available in the EHR, right, within the workflow? Or to me, I've been covering a lot of ambient clinical voice solutions that are just documenting it in real time. Is that where it's going, where all of this UpToDate information or whatever other clinical decision support stuff is pushed to the point of care for the doctor versus going to an app or going to a website or wherever it might be?
Yes. So our goal is to find ways to help busy clinicians to take the best possible care of their patients and to give them guidance that conforms to their workflow. So, interruptive alerts are sort of not good. So we want trying to be minimally or not all interruptive and really to make doing the right thing as easy as you possibly can to do that. So just to be clear, UpToDate already is and has for many years been available from the EHR. So we have a lot of technology to integrate. We have partnerships with all of the commercial EHRs, and we routinely get lots and lots of traffic from people who are already working in their EHR, and then they hit, an UpToDate button and they can get into UpToDate, right away from that.
Okay.
And then layered on top of that, we've got a lot of very advanced technology to take advantage of context from the EHR as well to render sort of more advanced and patient personalized decision support. That's a longer road to go down to do that well across commercial systems, but we are well positioned to be able to do that well. And then I'd sort of add that, the EHR is now and probably will remain to be the centerpiece for clinical workflow, but new workflows are going to emerge, and that's going to be driven by advances in technology and sort of market-driven needs. So you just mentioned one of them, which is the voice and ambient listening. So we have been working with the voice providers to find ways that we might be able to sort of artfully inject some knowledge support as people are interacting there. So all of those things are possible. But as far as EHRs and EMRs as being a place that is most conducive to sort of rendering knowledge support, that makes a lot of sense, so long as you do it exceptionally well and you don't bother someone and cost them time.
Yeah, that's fair. So talk to us about the future of this whole space, right? We talked about how do we understand this overwhelming amount of clinical knowledge, but there's also an overwhelming amount of data that's coming as well. What does the future look like for doctors that are, I mean, they're already burnt out, right? Like they have to go through so many patients, they have to stay up on their medical licensure, they have to stay up on the latest technologies, the latest data. I mean, it's a bit, I mean, it's, I guess, another contributor to the burnout factor. But how do you see this kind of space evolving and assisting doctors without overwhelming them?
Yeah, that is a wonderful question, and I've thought and wrestled deeply with some of the issues. So, and it's wonderful not only because of the ever increasing volume of clinical data, which I just mentioned, but also considering now the increasingly well documented risks of misinformation. So, if you bear with me, let me sort of try to break it down and really define what the problem is,
Sure.
and then what I see optimistically as some of the market drivers that are actually going to potentially alleviate some of these barriers, and then kind of give you a portrait of what a future state might look like. And then importantly, it's easy to predict future, but let me give kind of a timetable that's sort of grounded in reality.
Sounds great.
So the first is a point that we already covered. So information is coming increasingly from not just the biomedical literature, but now you've got lots of other inputs. So self-monitoring devices, new sites of care, like you're going to the CVS or the Walgreens or whatnot. And then you have the evolution of precision medicine, so pharmacogenomics, direct-to-consumer stuff, predictive models, real-world data, and that information is variable quality and accuracy. So points you already made. So one of the problems, number one, is clinicians have too little time in the day. So the number for most recently assessing how long it would take a primary care doctor to do all of their tasks would be 26.7 hours in a day. So you can't give them more stuff to do. So it's really important that information is given to them in ways that improves the ability for them to care for patients, and then not to contribute to the cognitive or work overflow that they're already having, the overload. And then the other problem is that, I think you were alluding to this a bit, EMR workflow is not designed to optimally support clinical decision making. EMRs were constructed really for other purposes. And so that's a bit of a challenge to try to sort of change that in real time, as EMRs have a lot of different uses to really be primarily or in a more substantial way supporting clinical decision making. Then there's challenges with data liquidity. Now we have 21st century cures and standards set by the ONC, but those are still variably policed, and some of the standards yet have not fully evolved and been adopted. Then you've got methods to curate information to ensure validity in critical high stakes domains. That's hard. You have to separate the wheat from the chaff and do that on an ongoing basis. And then very importantly, you don't have a lot of financial incentives to align investment into clinician-friendly information services compared to the many, many pressing near-term priorities of most care delivery systems. So that's the set of problems and why we've kind of not made as much progress as anyone would hope. But there's market drivers. So you mentioned one of them. You've got clinician burnout. It's severe, it's pervasive. I mean, my colleagues have just, describing it, and I'm sure you've seen it documented as moral injury, and because they can't deliver the highest quality of care. And you're starting to see punctuation marks on that with the recent strikes and unionization efforts. So this is sort of needs a new model for sustainable care delivery. And then you've got increasing dependence on advanced practice providers. There's a clinician shortfall, MD or DO, shortfall. So advanced practice providers are going to be indispensable for delivering healthcare services, and they're going to need knowledge support. And you've got the decentralization of care and resulting enhanced needs for data sharing. So that's in flight. And then, of course, this AI technologies and other advanced technologies are getting much, much better. You're going to have greater enforcement of interoperability and data standards. You've got new workflows emerging. You mentioned ambient, but there's other workflows that are emerging. You have kind of a financial backdrop where healthcare systems, which are trying to focus on top line and costs, are going to have increasing challenges in order to meet some of the margin constraints that they've been facing in recent years and coming out of the pandemic, but even before then. So eventually, and particularly if they want to take on risk-bearing contracts, they're going to need to be able to cutting into clinical care and start to stem that variability that's in clinical care and to deliver more uniform and efficient and high quality care. And the last point, not to be underestimated, is consumer frustration navigating a really dysfunctional and unaffordable system. So now let's get to timing for it. So I find it really interesting that we have an unprecedented high rate of clinician burnout and early retirements and all the things which are happening with there at the very same time when medical school applications have never been more competitive. So either the medical students are unaware or they don't believe the situation or pursuing medical degrees for different reasons than their forebears, or they're optimistically believing that the situation will improve. And I'm for that last explanation. So within the time frame of a first-year medical student who's going to enter practice, which is like 7-year plus, what could that actually look like? So I think we'll see early adopters and some mainstream adoption of tools that makes clinician jobs easier. So that will hopefully include approaches to deliver clinical information payloads. So all of that data makes sense of it and deliver it in a way that it can be consumed and that a clinician who's already very busy improves their ability to care. It doesn't just add. That has to be done thoughtfully. And I think you'll start to see that will become possible and necessary. And those will help to improve unwanted care variability. They'll be aimed at trying to delight professional users and patients across care settings. Some of those principles, this is not science fiction, those things are already here. So there's no technical barriers to achieving some of those principles to help and augment decision makings, to make sense of data, to improve decision making across populations and different healthcare professionals, types of professionals. What stands in the way is workflow, business model, and competing priorities. So my hope is that the reasons that I just described around market drivers are going to intensify to a point where they're actually causing these changes. I think they will. And so that first-year student who then has their first day as an attending physician hopefully will have a much better experience in all of these different dimensions.
Yeah, I mean, I would describe that last point as something that I've believed for a while, that the innovation is there, the technology's there, the data's even there in many cases, but it's just not equally distributed across every organization. And I think that is the challenge. So, I'm optimistic with you that this technology is going to improve the burnout variables for doctors and nurses and many in the healthcare profession. So it's very fascinating.
Absolutely agree. The amount of money flowing through U.S. healthcare, which is $4 trillion plus, and still has a very robust growth trajectory. Eventually, unsustainable has been sort of used for a long time. So at what point is it truly, truly, truly unsustainable? But I think the point is that when you look at health services delivery, it's pretty widely seen that there's a lot of waste. And a lot of that waste sort of comes in different buckets, but some of it's in that clinical dimension where it's discretionary decisions made by people who are actually doing the care. And those are the kinds of things that matter, and they could be very economically important. And more so than that, they actually can improve care. So I think that healthcare moves slowly despite all the froth that's out there. But I'm sort of optimistic, again, in that 7-year horizon, we're going to see a lot of favorable improvements.
Peter, this is exciting stuff. I love seeing that UpToDate's working on this. I think everyone wondered when it would come, and so excited to see that we're close to having this incorporated and the ongoing. I think we're at the start of what's possible. So appreciate you taking time to share your insights and perspectives. You obviously understand this at a very deep level, and I think my audience will really appreciate it. And thanks everyone for watching and listening. If you want to find more great healthcare IT content like this, be sure to check it out at healthcareittoday.com or search for Healthcare IT Today on your favorite podcasting applications. Thanks, Peter.
Thank you.